Hi, hope you're doing okay. My name's Kush and I'm a fifth year UCL medical student. Today we're going to be talking about chest infections and cystic fibrosis. We'll go through a short case, talk about cystic fibrosis and its management, and then go through an SBA. Don't worry too much about all the details. We'll go through the main key concepts at the end. Alright, so here's the case. Chronic coughs and colds. You're in hospital and you see a 13-year-old Caucasian male admitted to the hospital with a respiratory infection. It's his 5th admission in the last 2 years. He's got a poor baseline with a continuous productive cough and acutely a 3-day history of worsening purulent cough with a wheeze and shortness of breath. He was diagnosed with asthma as a child, but his inhalers haven't really helped that much. And he's got no seasonal or diurnal variation, no atopic features, no liver problems, and no smokers at home. He also has sinusitis, and in terms of previous history, he was born at 36 weeks with no issues, and he hasn't had any child health checks since. In terms of examination, he's unwell with a purulent cough and clubbing of the fingers, as you can see in the picture. He's got reduced chest expansion, dull percussion, and wheeze and crackles on the chest. He's got nasal polyps as well, and tenderness on the sinus pressure. His oxygen saturations are low, and he's otherwise hemodynamically stable. Differentials for this presentation would be things like asthma, bronchiectasis, chronic lung disease, alpha-1 antitrypsin deficiency, or recurrent pneumonias because of an immunodeficiency. And investigations to look at would be sputum cultures, chest x-ray, some sort of imaging, and peak flow or spirometry testing. The results come back and the cultures grow Pseudomonas, and spirometry shows a low FEV1 to FVC ratio, indicating an obstructive picture. Chest x-ray shows tram lines, as you can see on the x-ray, the parallel wispy lines in both lungs, and the chest CT confirms bronchiectasis. Bronchiectasis is chronic inflammation and damage and dilation of the airways. There are many causes, congenital ones such as primary ciliary dyskinesia and cystic fibrosis, etc. Acquired things such as post-infectious bronchiectasis and those associated with cancer and autoimmune disease. Together with the rest of the history, the sinusitis and the nasal polyps, it's highly suggestive of cystic fibrosis. And you do the sweat test, which is the gold standard, and it comes back positive, confirming cystic fibrosis as your diagnosis. So a bit about cystic fibrosis before we go on. It's an autosomal recessive condition, especially common in Caucasians. 1 in 25 of us carriers. The mutation is on the chromosome 7 with the chloride channel, and you get defective chloride transport across the cell membrane, which means that there's less water moving across the cell membrane because of the osmotic effect, resulting in drier, more thicker viscous secretions, and in the lungs this thick mucus clogs up the lungs, causing the damage. Mucus normally acts as an infection barrier in the lungs, trapping and clearing bacteria, and in cystic fibrosis the extra thick viscous mucus doesn't dislodge, and so bacteria colonize, and also it makes you more prone to infections because the barrier is not working properly. This causes congestion and a productive cough and obstruction, causing chronic bronchitis-like picture, and also if there's chronic damage and inflammation and infection, that can lead to bronchiectasis, as we saw in the case, and recurrent infections present with fever, purulent cough, crackles, and wheeze on the chest. Management of cystic fibrosis lung disease, so monitoring with spirometry and imaging like x-ray or CT. Chest physio and exercises are very effective to dislodge the mucus, and things like vaccines and good nutrition can also help the patient's health. Mucolytics can help thin the mucus, and bronchodilators and positive expiratory pressure to open the airways. Antibiotics are the mainstay of therapy. They can be prophylactic long-term or therapeutic for acute exacerbations, depending on the culture results. And they're targeted against whichever pathogen you find on culture, and these are classically things like Pseudomonas or Staph aureus or Haemophilus, etc. in cystic fibrosis patients. And social distancing is required between cystic fibrosis patients, as they can cross-contaminate each other with different bugs causing infectious exacerbations. Lung transplants may be needed in some patients with extensive damage, and other problems associated with cystic fibrosis like nasal polyps can be treated with steroids and removal, and antibiotics can treat sinusitis, which is another manifestation of CF. Lung disease is actually the biggest killer in cystic fibrosis, and people usually die from complications such as recurrent infections, respiratory failure, abscesses, superadded fungal infections, hemoptysis, pneumothorax, pulmonary hypertension, and right heart failure due to pulmonary hypertension, which is cor pulmonale. And so these are the biggest killers in cystic fibrosis because of the lung disease. And in general, if you see somebody with a productive cough, clubbing, and recurrent infections, or if something like asthma doesn't quite fit the patient, you should always think of cystic fibrosis and order a sweat test, which shows increased chloride, or genetic testing to diagnose the condition. It's a systemic disease. It can affect multiple organs, such as the lungs, so we've talked about the musculoskeletal system, causing weak, brittle bones and arthritis. It can affect the reproductive system, causing delayed puberty and male infertility, female subfertility. And you should always consider the psychological effects because it carries a shorter life expectancy. It's got chronic symptoms and illnesses, and there's a lack of patient contact. It can have quite a lot of psychological effects and stresses on the patient, and also on the family members and carers for the patient. In terms of the outlook, it's important to maintain a specialist multidisciplinary approach and involve the family and support groups to help the patient. Newer treatments have come out which help the expression of the functioning CFTR proteins, and these have been shown to improve prognosis, and there are plenty of new gene therapies and stem cell treatments on the horizon which can hopefully be used for treatment in the future. On to the SBA. So you see a 23-year-old male patient with cystic fibrosis in A&E who is coming with a productive cough, green smelling sputum, crackles and wheeze. Colmox clav doesn't work, and the cultures come back showing a gram-negative rod. So which is the best antibiotic treatment considering the most likely infectious agent? Is it flucloxacillin, metronidazole, benzylpenicillin, piperacillin tazobactam, or vancomycin? So you can have a think and pause the video if you'd like some more time. It's a tricky one. The answer is number 4, piperacillin tazobactam. It's a likely Pseudomonas infection, as that's a very common bug in cystic fibrosis, and it causes green sputum. And Pip-Taz is the only anti-pseudomonal antibody. But obviously always check local trust guidelines, and the other antibiotics don't treat Pseudomonas, and the anti-Pseudomonal antibiotics are something they always like to test in exam questions, so make sure you revise which groups of antibiotics can be used against Pseudomonas. Alright, that's all. So here's a summary of the key points that you need to take away from today. So recurrent chest infections in children or adults can signify many things, but remember, always consider cystic fibrosis in your differentials, especially if there's clubbing or productive cough. CT and spirometry are very important, and the sweat test or genetic testing can be used for diagnosing cystic fibrosis, features of which include bronchitis, bronchiectasis, and recurrent infections, especially with things like Pseudomonas, which is especially hard to treat. Pulmonary disease is the biggest cause of mortality and requires good management, things like physio, mucolytics, inhalers, vaccines, and of course antibiotics. And remember that cystic fibrosis is a systemic, lifelong illness, and it requires specialist multidisciplinary care and good support for the patient and for the family. Thanks very much for your time. That's all from me. I hope that was useful for you. Here's some resources you might find helpful. If you've got any questions, feel free to email me. And otherwise, thanks very much for your time. I hope that was useful. Bye.